Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. And today I have a guest who actually was a resident of mine. Today I want to speak to Alan, who was my family medicine resident, but he decided to practice emergency medicine. So he has an interesting story on how a family medicine or a general practitioner ends up in the emergency room. Welcome, Alan, to PEM Rules. I'm very happy we can do this today. And today we're going to talk to Alan, who has quite a unique story. As I mentioned in the introduction, Alan was my resident. He is a family medicine trained physician who practices emergency medicine. I'll just say a few details, and you're going to stop me at any point if I made a mistake, Alan. Alan is originally from Boca Raton, Florida, went to medical school at Ross University, graduated in 2019. He then completed a family medicine residency at Advent Health Winter Park family medicine program. I was working in Orlando at the time, and I was attending when he did his PEM rotation. He graduated in 2022. And Alan always had passion for emergency medicine, I think from the big time I knew him, at least. And since graduating, Alan has been a community emergency medicine physician despite completing family medicine residency. That is something that is not at all unusual. Many EDs in the country are staffed by non-EM providers. And I guess, Alan, you gave me these statistics. I'm going to ask you where you got it from, but nearly a third of emergency care in the US is provided by family medicine physicians. Some may be freestanding emergency medicine department or urgent care classifications. In the early 1990s, board certification became required. And eventually in early 2010, most states passed mandates that required the American Board of Emergency Medicine trained individuals to work. However, rural America has not been able to catch up, and rural medicine still has high volume and obstetrics and pediatrics. Some rural communities often have family medicine physicians. The ratio that I understand between the doctors, there's 7 family medicine docs for every EM board certified physician. Is that right, Alan?
Correct. Yes.
That's incredible.
Yeah, and thank you so much, Yoram, for having me on the show. I've been still to this day, we're 2 years out of residency, and I still certainly knock through a few of your podcasts when I'm on a few months of study grind. Certainly a lot of self-study in the community and rural field, partially just because, in a big, massive center, you see a lot more high acuity, high volume, where I see high acuity much less in a lower volume setting. Though sometimes we do have high volume, you just see stuff less frequently, but I end up being the one that kind of manages a lot more of that, from deliveries to procedures to, everything in between. Some days I'm the hand surgeon because trauma in hand at the main hospital about 2 hours away that I fly people to doesn't have availability, or they don't think it's critical enough to transfer immediately. So, I find myself doing procedures that I have exposure and experience to, but the community needs it. And to those statistics, and actually it's funny enough, the EM journal that I belong to, as well as ASAP, just published another study about the discrepancy that is plaguing rural America, especially after the COVID financial boom that supported a lot of rural communities during the pandemic, and that money kind of has fizzled out. So you have a lot of rural ER shutting down and staffing reducing and resources reducing even more so in those spaces, and it deters urban center, I'll say experienced ER trained residents from going out and doing that work even more so now, because they have even less resources, and they don't to understanding, they don't want to be floating out in the ocean surrounded by sharks. Sometimes they prefer to have the resource and the tools that they were trained to use.
I understand. Very interesting. And that is exactly what I wanted to have you on the show, Alan, to talk about those experiences. And my first question to you, Alan, it's a question I ask all my guests, as you know. What is your definition of a good PEM or EM provider? One who does what?
Yeah, and it's pretty special to get this question because it's one that I think every doctor probably reflects on regularly when they're doing things really well and when they're making mistakes. And I had an attending Dr. Weiss at Advent Health, Winter Park, who had a book that he always had us read when we did our geriatric rotation with him about what makes a good doctor by Max Griffiths. And I found it to be, if anything, just valuable introspection during your I think it was end of my second year in residency. I had spent many months working through COVID, understanding, the difficulty of part of the field of medicine being helping people, saving lives, and also just providing quality care and honesty, compassion when that's really all you can provide during extremely difficult pathologic, during extremely difficult times in medicine with certain diseases. I don't think there's such thing as the perfect provider, especially in the current hedge fund owned and operated, metric driven fields of medicine. Emergency medicine, I think, takes on that huge burden. But one of the beautiful things that rural medicine provides, you get to go back to kind of what we all are force fed in medical school, which is the roots of practicing medicine. You get time to ask detailed history and histories, and ask about their past medical, ask about their diets and their health. You get to go in and use evidence-based medicine, but complete detailed physical exams, because sometimes you don't have I'll go a week or two with a CAT scan with my CAT scanner machine down, and sad to say, there's only one, and I only have MRI 2 to 3 days a week during 9 to 10 a.m. to 5 p.m. And these criteria and evidence-based approaches using Canadian C-spine and Heart and EDACUS score and Wells score and all these things are fantastic. But you'd be surprised how often, they fall short when just a couple extra questions, or a little bit more involved physical exam or looking through some charts can really provide a better quality of care and create what I would consider is a good provider. You look at reviews on Yelp of certain hospitals, and doctor walked in, didn't even touch me, and then told me this and this was wrong. And don't get me wrong, sometimes you don't need to examine in detail the ankle of the kid who walks in and he can't stand up and instantly meets the Ottawa score. Get an X-ray, you go in, you can check the pulse, the sensation's good, tell them, hey, ankle's broken, we'll splint you up and get you going. 30 seconds. But that, I think, falls short of that extra little bit of compassion, which those metric-driven emergency rooms kind of lose. And that's one of the things I appreciate in this field. Sometimes it is exaggerated. Certainly people have personal feelings. I have some of the reviews on Yelp that are about, the sandwich in our ER is terrible, 1 star. And you look and you go, why is the emergency department got such terrible reviews? Or HCAPS, oh, the nurses were talking bad about me, but maybe they're discussing another case and you just don't have a big enough space for privacy to be perfect. And you try to optimize these things. But the biggest thing I was always explaining, Dr. Weiss really showed me, was how do you build rapport? How do you get a patient to trust you and appreciate you and respect you and want to listen to you in 2 minutes? And I think that's one of the things that I always cling to, and providing good quality care and being a good provider. Sometimes it's a joke, oh, what are you doing here, young lady? To your 90-year-old wheelchair-bound vasculopath who, has a little back pain, and you're kind of like, they probably don't need to be here. But, showing them that appreciation, no differently than if this was your grandmother who is scared and concerned, and, putting your hand on their shoulder when you're listening to their heart and lungs to kind of add that extra layer of compassion and understanding that, they don't feel well. They're scared. This might be one of the worst days of their entire life. It's another day in the office for you. But I think that for many of us, we forget that. We forget that this person in the seat in front of us isn't a metric, isn't just a lab test or an imaging study. It's a human being. And, I remember and always appreciated working with you, Yaron, when you would go in and your bedside manner and how you loved kind of telling the patient's parents, hey, this, my ears, the throat, this, like you're going and walking them through the care plan, and then you're educating them. you're giving them the tools. I know that, their throat hurts and it seems like it's probably a bacterial infection, but we're not finding that. And supportive therapy is really what's needed. And you're reassuring them. Your reassurance adds that level of good quality care, your cadence, your confidence. Though these people sometimes want and expect a medicine, prescription, an antibiotic, you give them this understanding that, we don't want to create these superbugs. Your child down the road will increase the chance of getting sicker with radiation, with this and that. It's important to always be applying these new and best practices of evidence-based medicine. But I do oftentimes feel that one of the best qualities of a good provider is just the compassion and the education that can be provided with those extra couple of minutes in the beginning and the end of those visits. So that would be my best answer to what I've definitely gained insight into practicing in a rural field where, sometimes there's not the answer they need and they're not going to get into the specialist today and they might be sitting there for a day or two waiting to be transferred. And, you understand their time is valuable. They're sick. We want to help them get better and that, we're here for them. So.
Absolutely. Very, very good answer. And I appreciate the compliment. And I agree with everything you said. Absolutely. It's another day in the office for us, a horrible, very scary day for them. I totally get it. And you kind of take it for granted at times. So thank you very much for that answer. I'd be curious to know, Alan, if you can tell the PEM Rules listeners, and again, this is pretty unusual situation. I've worked with many, many family medicine residents. You've always been very passionate about emergency medicine. What made you fall in love with emergency medicine despite your family medicine background and education?
Yeah, so I did a decent amount of rotations in med school and emergency medicine after having done a great third year rotation. Fell in love with it. That was really my main direction. And unfortunately, for myself, I think I either stretched myself a little too far with where I applied for residencies, or I missed the mark a little bit on whether it was board scores or just kind of my understanding of my roles. And I found myself being a great match for an amazing family medicine residency that had, one of the top programs in the country, luckily enough for me, great attendings. But during my first year, I was kind of going back and forth in my heart what type of medicine I wanted to truly practice. Family medicine allows you to do a lot of different styles, whether it's full spectrum or women's health or sports medicine. And this thing called the COVID-19 pandemic broke out towards the end of my intern year. And my hospital, as well as the one you were working at, had a call to arms. Anyone who was experienced and competent to come help. And my secondary center, the Advent Health in Winter Park, did not have any other residency other than our family medicine one. And the ICU was overloaded, 25 to 30 patients, filled up PCU beds on vents, BiPAP intermittently, decompensating regularly. And they were asking anyone, attendings who hadn't been in, acute care for a while, or even residents who had just maybe done a couple months in inpatient or ICU. Thankfully, I had a lot of competence from my med school rotations and some good family med first year intern rotations. And I jumped in the deep end, this understaffed and, basically now massive ICU that I was managing my own, at some points, 10 to 12 ICU level patients with nurses working with 4 to 6 patients at a time, the attending taking on 20 plus. It was scary, but I fell back in love with acute care, acting and interacting with these patients as things were happening, getting in imaging when something was changing, chest tubes, intubations. And I gained some skills that I was like, whoa, these skills are going to be so valuable for me if I were to chase that dream of maybe working in the ER. And I wanted to see if there was still an option out there. These attendings that I worked with, they were always so supportive of, following and chasing what space in family medicine was important. Dr. Fishberg was one of my attendings, and he, in his early career, would go out and moonlight. I think it was like the mid 2000s, out in like rural Alabama, and he explained, a lot of the specialty is family medicine. You have these people coming in high blood pressure. They're not symptomatic. They're not hypertensive emergency. Having ischemic cardiac or liver failure or, encephalopathy. They're just, they don't really understand why I got a headache and they have high blood pressure. And so that space, that gap in between, I felt like I was being trained so well at Advent Health that I could go do it. And I was right. We had a non-OB space at our main facility, the Women's Center at Advent Health. And I was doing, at one point, I think it was like 4 to 8 deliveries my intern year in a 12-hour shift. And I was like, you know what? I'm getting confident with this field, this additional field that I found myself needing, rural medicine. A lot of my patients come in, they don't have OB care, or they can't get over to the provider because it's an hour to 2 hours to get to their OB provider. And I've delivered babies. I think I've delivered 4 or 5 in my rural center with limited tools, doing bedside ultrasounds because at times the tachometer is not working, checking in with OB and surgery and flight team to get prepped. And confidently so, I've the field has opened itself to me because of the diversity in my training, doing derm procedures, doing pediatric care management because the pediatric facility doesn't have transfers available. So we're monitoring and doing oxygen and, nebulized epi for hours to even a day or two till we can get transport to the main pediatric center. So I would say that it kind of was something I've always been chasing, and I found a really great space that I can be the primary care provider that I was trained to be, with this confidence in emergency medicine that I took the initiative to gain. So
excellent. Those sound like
yeah.
you were very lucky in a way to go where you went and also have that passion. And you kind of alluded and answered my next question, Alan, which is probably the most important question I think people are curious about. What are the challenges you face or faced as a family medicine trained individual working in the ED? What challenges do you have in your practice in the community? Probably have some limited resources. Tell us a little bit about that.
Certainly. And, I work in one rural emergency department, and then I work in some freestanding emergency departments over in Albuquerque. And it's a really great dichotomy I get to experience. Also coming from Advent Health, where every specialist imaginable existed in that facility, in that Orlando main hospital. And, I think some of the biggest challenges at first, and when I started, I thought it was going to be my own, exposure, experience, competency, knowledge. And I found that, with my dedication to continuing to learn, and study and, make sure that I'm giving the best quality of practice, those challenges started to fade. But the real challenges I started to notice were what is lacking in my center. I don't have pediatrics. I don't have OBGYN. We actually just lost our general surgery and orthopedic surgery contracts. So a lot of my cases have to get transferred out. I can only do so much when it comes to joint reduction, when it comes to an acute abdomen. And you have a snowstorm here in my facility, or you have an ICU critical patient that's on a ventilator, and I have 8 people in the waiting room, and there's no available transport, whether it's because they're going too far because the nearby hospitals don't have beds available. So I have to be my own secretary, calling out hospitals all throughout the local area within 3 to 5 hours to get transport, or even just, oh, we don't have a flight till tomorrow because one of the choppers or one of the planes is down, or there's too much wind and so they can't take off. The consults I have are always so helpful, but they're not there. They're not there to see the patient or take them back to the OR. The training I have and the specialized extra education I do with ECG Weekly, and I do I say every few months I do online conferences. Gaining that confidence is fantastic. But if I don't have cath lab access and I have a patient that would benefit, pushing TNK, getting heparin going, it really is only buying me so much time. One of, I'll say, the biggest benefits, but also one of the biggest challenges is education lacks in the community too. So you do have people that are just like, I don't want to wait here. I don't want to be transferred. And I have to work with them and explain, this is serious. You need to go to another hospital. If you're going to walk out of here, And sometimes they do. Sometimes they leave my ER. I had a farmer that had a bullhorn that went through his shoulder. And he was like, well, can you remove it? And I was like, well, you have partial pneumothorax. I'm not a surgeon. If I pull this out and there's any injuries to your subclavian or something, I can't fix this. We need to transfer you. He's like, nah, I don't want to. And he literally got in his truck and drove to the main hospital an hour and a half, 2 hours away. Now, I obviously, HIPAA and EMTALA, I didn't tell him to do that, but I certainly begged him, please don't go home. So there are limitations that people can't fathom. And, there's a fantastic video YouTube channel that talks about the ER doctor. I think it's like Flanagan. He's an ophthalmologist who does these hysterical videos. And he talks about this rural community that he pretends to work at and how the radiology tech and the EMS transport, and their interventional radiologist is all their boat driver, who drives people through the swamp. And there are times where it really does push comes to shove out here with this. I play OBGYN, intensivist, trauma surgery while they're walking me through things on the phone. It's a luxury because sometimes, and I've had ER docs I've worked with that make jokes saying, oh, this guy's doing real emergency medicine. Though it's not true to some capacity, when you're at these bigger facilities, oh, this is what's wrong. Boom, you call upstairs. Gen Surg comes down, takes them away. Ophthalmology comes down and does their slit lamp exam and eye exam and does all that for you. And so it does create this skill and experience, that I'm gaining more and more of. But it also certainly is something that without having emergency medicine residency training, it is learning a little bit more on the fly and with guidance consults. So there's a lot of little limitations. Knowing to step back from my own ego, I think it's one of the most important parts of making sure those limitations don't allow anyone to get hurt and that the best quality care can still be provided with these limited resources.
Very good. I'm sure you have, like you just told us, I'm sure you have some very, very interesting story about your experience in rural medicine, which leads me to the next question, Alan, is what are your advice for people like you who did the residency, let's say in general pediatrics or internal medicine or family medicine, and like you either from the very beginning or maybe towards the end started gravitating towards emergency medicine? What advice do you have for them? Do you regret not doing emergency medicine residency? Are you considering it? What would you tell those people?
Yeah, and I think just like in every field, especially when you're struggling or when the hours are long or when you're tired, you reflect on, did you make the right choice? Sure. I contemplate, should I reach out to UNM, who I know them very well now. I talk to their ER docs all the time. Could I go back and redo residency and still stay in the home that I have, or go back to Orlando, which, funny enough, at the end of my third year, after doing multiple rotations, I was offered an opportunity to start back over. And I think in my reflections, I've kind of realized I am very happy in this space. This community appreciates my care, the quality care that I bring with me every day, the energy I present and show up in the ER with. I see it in my HCAPs and my Yelp reviews and hearing it from patients who come back and write a letter and say things like that, and from upper management. I think, there are places throughout the country that are in dire need of good quality practitioners, and especially those who love this field that maybe don't have, the highest level of training. There's definitely still a difference between the ER doctor trained in an emergency medicine residency that has all the specialists and everything they need, and they're sitting in a library or studying most of the time versus getting the hands-on training, versus the ones that are in certain facilities that, get their 10 intubations required within the first month. Skills, knowledge, the criteria, knowing how the medicine is changing, all that is important. But at the end of the day, it's care and compassion and reaching out and utilizing your resources and your specialists as needed when you can, or when you can't do things or you need backup. And I think that for a Gen Peds who is considering doing a fellowship, which I think that is somewhat more standard, But the internal medicine and primary care doctor, there are ERs where you can do both, where you can still be a family doc or an internist, and you can be full spectrum, and you're still getting some of the enjoyment of the acute care, the sicker, more complex disease, and the immediate reaction interaction type patients. I work with a doc who's an internist in the afternoons, and internist in the morning, goes and sees his clinic patients in the afternoons, and then once every week or two he does a night shift in the ER. And he loves all of it. He loves the combination. He likes to be able to see his patients in the ER, providing them care, supporting them, changing their medicine, and going, I'm going to follow this up in a couple weeks. And it's so there is a really special place and a huge need still. And as mentioned in the beginning of this podcast, the statistics show it too. There are rural ERs that are hurting, and not saying the ABEM trained, the fantastic residencies out there. And I remember working in so many of them during med school, but it's a different type of care. The 5 to 6 patients an hour, the running between doing procedures, teaching, doing this, that same type of care isn't needed in a space where, and don't get me wrong, sometimes I have 4 to 5 patients coming in an hour, and the ER waiting room is 10 to 15 patients, and it's nonstop. And I have sick people coming in, ambulances nonstop. But a lot of the time, you're working in a system that is setting up follow-up, setting up education, starting them on medicines, seeing how they respond to these medicines, and rechecking in and telling them come back in a couple of days because they don't have primary care. And a lot of them are on Medicaid, Medicare, that's kind of the next best step so that they're getting the follow-up they need. I certainly wouldn't change my path and my journey for anything. I found an amazing love and partnership through the journey I chose and the time I got in family medicine, to get to have some of the time during residency to be able to actually see my partner and not working 20 shifts a month. I found an amazing community and home in Santa Fe, New Mexico, where I do, though it's not the shortest, it's an hour, but it's all highway. It's beautiful in the Rocky Mountains. My commute to work is amazing. The community appreciates the care, and I am blessed to have the access still to the work and the jobs. And though, there may be limitations, and this is one thing that I think does need to be considered always, how the field is changing and how ASAP and SAEM are trying to phase out, the family medicine doctor from the specialty a little bit. I think there's a protection still in these rural communities where those doctors still just aren't going to. But at the end of the day, I don't think this field is a 30, 40 year, 14 shifts a month, nonstop, go, go, go. I think it drains on your soul a little bit too much. That, many of the younger docs I know are already talking about phasing out, wanting to work a little less. And I enjoy being that Swiss Army provider that can, support and be the primary care and the pediatrician and the intensivist and the ER doc all in one. And, whether you're a Harvard EM doing ECMO, in the field, and nasogastric, nasotracheal fiber optic intubation, and have these amazing skills, which is needed in so many spaces. Or you're lacing up the 12-year-old sprained ankle and explaining to him, how tight you want it and to elevate and, do the rice therapy, and looking him in and going, if you want to get better so you can make your football game, you're having this human compassionate conversation. You got to find a balance in your work and your life, so that you can have a long and happy career in the space. And I feel that is certainly obtainable. And I have obtained that here in this community.
Very good. Truly, truly inspiring, Ellen. I really mean it. I admire what you do. I think that's certainly very different, very brave. And again, I think you absolutely gaining some wonderful, wonderful experience. Doesn't surprise me. You're an excellent resident with a lot of passion from the days I knew you. So I'm not at all surprised, but really very, very impressive and inspiring story for following your dream and finding kind of a unusual way about it. I appreciate you coming on the show, Ellen. Thank you very, very much. And again, you know the drill because you know the podcast. You get to choose the outro. And I guess you wanted to hear Smooth Criminal by Michael Jackson. It's a good choice. It's a very good guitar riff. You like Michael
Yeah.
Jackson?
Yeah, I mean the King Pop. Yep, no question.
Absolutely. So, in honor of you coming on the show, I'm going to have to play Smooth Criminal by Michael Jackson. I guess I'll have to figure it out. It's kind of a fast song, but hopefully I'm up for the challenge.
I believe in you, and thank you again for having me on. I still certainly knock through a few of these when I'm going on my pediatric videos and reviews, and I know that there are many residents out there that are gaining so much insight and knowledge from your expertise, and I think you're very true and honest way of practicing pediatric medicine. So thank you for what you do and for your time.
I appreciate that. Thanks again, Ellen, and have a wonderful shift. I know you're on the way to the ER, so have an easy one.
Thanks. I appreciate. I'll take that. Good luck with me.
Thank you very much.
You're welcome.
And that is it for today, guys. Thank you very much for listening to PEM Rules, and thank you for listening to Alan's story. Important to remember, not all the people who work in the emergency room are necessarily trained in emergency medicine. We do need a lot of help. Thanks again for listening. Please check out the Facebook page, check out the website. There's also now a PEM Rules online store to purchase some merchandise. Thanks again and have a great day. Here is my attempt to do Smooth Criminal by Michael Jackson. I think that song is somewhere from the 80s.